So I could choose what I wanted. And then I was discouraged by everybody, including my teachers, my mentors, family members, that surely you don't want to go into surgery. That's a man's world. You don't stand a chance kind of, competing with men there. So first I want to start by saying that, women's health hasn't had the due attention it needs. It's massively underrepresented in research. And also women's health issues can often be dismissed.
If you're from a certain culture or background, it's, don't talk about period. Sometimes you're not comfortable with how we actually going to progress.
And I think what I've found is, women look up to kind of role models within their own community. And also women's health issues can often be dismissed by women themselves and also healthcare professionals, as because the symptoms often are of pain. And pain is so subjective, and it can be treated as normal. Menstrual cycle is normal, menopause is normal. It's part of your life. Why are you making a fuss about it? Just get on with it. And they may not be taken very seriously. But thankfully, it is getting more recognition now. So given that it's been underrepresented, I do feel that, we can do a lot more in that area, but it needs collaborative working. What it doesn't need is a top-down approach.
And one of the things actually one of the women mentioned was, her husband telling her that actually my mum went through it. You're going through it is absolutely fine. She got over it. She did well. You'll be fine. Yeah. And she was just explaining how that made her feel. And yeah, you're right. Sometimes they're not going to come to you. Then it won't come forward. How do you suggest we kind of go to these women in these different communities? My name is Saira. I'm practice manager here at HIOS GP Practice. I also work as part of a PCN, so Primary Care Network, which is Great West Road, which is a group of GP practices, and I help with kind of innovation with the PCN. Do you want to introduce yourself?
Yes, thank you, Saira. It's lovely to get to know more about your role. I'm Archana Dixit. I'm a consultant obstetrician and gynecologist based clinically at the Middlesex Hospital, which is part of the Chelsea and Westminster Trust. Now, of course, being a gynecologist, I'm very interested in women's health, surprise, surprise. But also over the last few years, I've become really passionately involved in the community of Hounslow to try and promote women's health, reduce health inequalities, and really kind of bridge that gap between secondary care, primary care, and the community. Because, if we all work together, we can achieve loads more.
Yeah. It's all divided. It feels like it's all divided at the moment, doesn't it?
It is, yes. And everybody seems to be kind of wanting to protect their own patch in some ways. But there are things, what I've discovered is there are a lot of individuals invested in this work and equally passionate in primary care, in the community, in public health. And we just need to find all those people and bring them together.
And actually, we're all working on the same thing, aren't we? Like, we have meetings after meetings and we're like, yeah, actually, we want to work within this area. And then we meet someone from secondary care and they're like, yeah, we're also working on this. It's just about how do we come together and actually...
You've hit the nail on the head. It's we are all working for the same goal, but we're all working in our silos and we just need to collaborate better.
Definitely. So before we get started, I actually wanted to talk to you a little bit about how you got into your role, because we have a lot of young people coming to us. They want work experience. They want to understand the different roles within the NHS. Did you always know what you wanted to be when you were, say, 16, 17?
No, I think I knew that I would like to be a doctor, but we are going back many, many years. Yeah. So I was born and brought up in India and did my medical school and actually my obs and gynae training there as well. And to be honest, in those days, it was either you became a doctor or an engineer. Maybe some became lawyers. Yeah. Forgive me for saying this, but I think it was more like if you had a daughter, being a doctor would be something you were meant to be. But anyway, I was interested in it. I had a scientific brain always. So that's how I became a doctor. And then why I took up obstetrics and gynecology is another interesting story. I wasn't keen on it to start with. I actually wanted to be a surgeon.
Who doesn't? Again, everyone wants to be a surgeon.
Exactly. The glamour, maybe it was the TV shows that excited me. But anyway, and I, in India in those days, you had to sit a kind of exam all over the country, and I, by God's grace, had a pretty good kind of score there, so I could choose what I wanted. And then I was discouraged by everybody, including my teachers, my mentors, family members, that surely you don't want to go into surgery. That's a man's world,
Interesting.
Men, you don't stand a chance, kind of, competing with men there. And the naive me, I don't think, if it was me now, I would have stood up and gone in, but I didn't. And it was almost like, well, why don't you do obstetrics and gynecology? And I thought that sounds very patronizing. But what excited me about it was, the more I learned about it, was that it is such a great mix of medicine and surgery, because, gynecology, you do a lot of operating. Of course, with obstetrics as well, you deliver babies by cesarean sections, and it requires a lot of skill to kind of manage pregnancy and pregnancy with other medical conditions, which is what I ultimately did specialize in as well. So yes, that's how I got into it. But I must say, there's not a single day that I've regretted taking it up. I immensely enjoy it. And I think it's the most rewarding specialty, especially, the obstetric side of things is so unique. And at the end of it, when you have a mum and a baby,
very rewarding.
Absolutely. Absolutely. So yeah, all the aspiring doctors, not just women, men too.
Yeah.
I would say, do consider obs and gynae as a specialty choice.
So interesting though, just a comment like that can change your mind, isn't it?
Absolutely.
So don't worry, guys. Don't let anyone get you down. Go with what you believe in. So a lot of the time people want to know what you do like day to day. So talk us through like maybe this morning, what you've got up to, what are the day-to-day things that you get up to?
This morning might not be a great one to choose because I don't officially work on a Thursday. However, if I take you to kind of like a routine day for us would be generally either doing a clinic or a theatre or covering labour ward. So the day would, for me, currently, for all sorts of reasons, the day typically starts at 7:30. I'm at the hospital at 7:30, not to start my clinical work, but, to catch up on admin, do a bit of kind of education. We have kind of medical student tutorials in the morning between 8 and 9. So often, not just me, of course, my other colleagues as well. And then typically a clinic would start at 9 a.m. Where you will have kind of a list of patients. It'll be yourself. So as a consultant, I will be there and I'll have one or two resident doctors or trainees. And you see women. If it's an antenatal clinic, you see pregnant women. Generally, we tend to see only pregnant women who have some sort of medical or problem in pregnancy, because our midwifery colleagues who are very well equipped to look after kind of normal pregnancies. So we would see people with any kind of complex issues. If it's a gynecology clinic, of course, we see an array of women in our general gynae clinics with a lot of kind of women's health conditions. And that would typically run till about for 4 hours on an average, give or take. And then we would have our afternoon commitments, which could be another clinic or delivery suite or operating in theatres. Some days we finish at 5.
Okay. Other days?
Things may go on for a bit longer. And when we tend to be on call, then, you would go and be on call for labour ward and gynecological emergencies. And then depending on when you finish, you would go home and be on call from home for the team, a fresh team, which would come and be there at night. So does that kind of give you
Yeah. I mean, you've got a little bit of, it's nice that you've got a mix of things that you're doing.
Oh, absolutely, yeah.
Is there like flexibility? So you mentioned that when you do like the night shift, so you're on call, then say the next day, because it can be quite, do you get a break then the following day?
It depends on what kind of, if you have been in the hospital all night, and some of our colleagues, and the trainees would be resident at night, then yes, they would not be working the next day. They go and they might come back for another night, some of them. But if you have been there till say 9 p.m. and then gone home and been on call over the phone, yes, you are back next day doing your usual commitments.
Okay, interesting. Okay, you mentioned the kind of most rewarding things about your role. Is there something that you don't enjoy, or on the bottom of your list of things that you enjoy?
Of the list, probably all the admin stuff which comes with it, and I'll be honest with you, I'm sure it's across the kind of whole NHS. Slowly over the years, the support staff we get for admin support has slowly started dwindling. So a lot of it is on our plate. And it can sometimes be tricky to be able to keep on top of it. And the other things I don't enjoy are meetings that don't go anywhere.
Oh God, don't get me started. We all know about those
Constructive
meetings.
I definitely enjoy, but yeah, we all know about some
For the sake of having meetings.
Exactly. When I could be looking after women, I could be interacting with women.
Exactly. So you wanted to come on and talk about kind of collaborative working. We mentioned a little bit about kind of primary care, secondary care, community not doing the best to come together or working together. But yeah, what are some of the things that you think that we could do to kind of help with women's health?
So first I want to start by saying that, women's health, sadly, over the years, hasn't had the due attention it needs. Half the population is made up of women, but they kind of have lagged behind in terms of, I won't talk about other things they've lagged behind, but certainly in women's health, massively underrepresented in research. And also women's health issues can often be dismissed by women themselves and also healthcare professionals, as because the symptoms often are of pain, and pain is so subjective, we know. And women can be, and it can be treated as part of normal. Menstrual cycle is normal, menopause is normal, it's part of your life. Why are you making a fuss about it? Just get on with it. And they may not be taken very seriously. So I do feel that it's an area, thankfully it is getting more recognition now. So given that it's been underrepresented, I do feel that we can do a lot more in that area. But it needs collaborative working. And what it doesn't need is a top-down approach. We shouldn't be deciding what women need and then give it to them or tailor our services based on that. So it really needs a collaboration between healthcare professionals, between policymakers, but most importantly, the women from the community need to guide us as to what their needs are. If we take the example of Hounslow, we have a national kind of women's health strategy or whatever it might be. But is it truly applicable to the needs of our local population? And no nation can truly, especially we are all so diverse now. You can't create a national strategy which would be applicable to every area. So I feel that, within Hounslow, if we have truly collaborative working between secondary care, which our local hospital, West Middlesex, is, with our primary care colleagues, so people like yourselves and the GPs, the practice nurses, but also involve, very importantly, those women whose voices are never heard. And believe me, we've been doing a lot of engagement work with women in the community, and all women have something to say. So, and the ones who get left behind are those who are perceived as kind of, not being good with the language or, and there are lots of barriers, we know, social, cultural, language, but, you just have to find the right way of communicating with these women, and they have so much to contribute, so much positive stuff and ideas come out of these meetings, which we may never have heard of.
Definitely. And you mentioned Hounslow is very diverse. We've got so many different cultures, different religions. But you're right, access could be a problem. Or like you mentioned, sometimes people are going through this, different things and they think, well, it's just normal, or maybe my mum went through it, my sister went through it. Yep, it's fine, just get on with it. We actually run group sessions. So we brought in, kind of sent messages out to patients saying, specifically for menopause, this one. And we thought, let's just bring in a group of people, let them know, look, come along, let's talk about menopause. It was a group of, say, about 10 women and all different, backgrounds, communities. And one of the things actually one of the women mentioned was, her husband telling her that actually my mum went through it. You're going through it is absolutely fine. She got over it. She did well. You'll be fine. Yeah. And she was just explaining how that made her feel. And yeah, you're right. Sometimes they're not going to come to you, then it won't come forward. How do you suggest we kind of go to these women in these different communities? Because if they're not coming to us, how do we go to them?
So again, these were questions which we raised when we started this work about a couple of years ago, and what the thoughts that came to us, and that those have worked for us are, faith groups. Those are really, really good because women do come together in their within their faith, and so if you approach the right people, say in mosques, temples, gurudwaras, and go to it's amazing. We found a lot of women's events do happen, and then if you just ask for some time, they welcome you with open arms. Actually, there are a lot of community groups. Women have their own groups where they meet regularly, socialize and do things for each other, help each other out. I've come across so many. There's a Thringen group. There's one group, women call themselves, they're all over 65. They call them Young at Heart. And, a large group of women. And then there are community connectors as well within the Hounslow Public Health team who can help put us in touch with women. And interestingly, or like you'd said about the menopause, I recently did one through the Lambton group in the leisure centre. And there were about 30 women who came. And interestingly, and what I really liked was there were 2 men who came. And I think we do need more men to attend these kind of sessions so that they can truly understand, of course, within what women will feel comfortable, of course, having men there when they want to come and do a talk heart to heart. But I think, for many of the women's health issues, we do also need to raise awareness of them amidst the men so that they can understand those issues and be better at being able to support, be it their mother, their wife, their daughters, their sisters.
Because it's a cultural thing as well, isn't it? Because sometimes you don't talk about these things, if you're from a certain culture or background, it's, don't talk about periods, you don't talk about, and then, like you mentioned, sometimes you're not comfortable with having someone there, like who's male, but how do you change that? How do you, how are we actually going to progress?
And I think what I've found is, women look up to kind of role models within their own community. And if we manage to find those people, of whom there are plenty, these advocates for women within their community, and they are really good at connecting and encouraging those women to come and attend these sessions. I think it also helps if you have, the people who are going to talk to them. These women can relate to them, those who look like them and who can talk their language, be it with an accent, It
does make a difference.
It does make a difference,
Yeah, because I think a lot of the time, if you are talking about sometimes we see posters in the NHS. When you see posters and you see that typical person that doesn't look like you, maybe talking about something that is already, oh God, I don't want to, smears, for example, is a good one. Cervical screening. Yes. Whenever you see posters, you see, leaflets, and it sounds all complicated, and you don't relate to it. The person doesn't look like you. The language isn't something that you can relate to. So it's quite difficult. People. Think it's not for them.
I mean, if you imagine, I'm sitting there talking to women from the South Asian community who look like me. I'm a bit overweight. If I talk to them about the struggles of, how to control your weight, how to control your carbohydrate portion size, I may be wrong, but I think they will, it will come across as more powerful than if they had a very slim person sitting and telling them about things, and they think, well, you can achieve that.
You can't relate to me.
Exactly. You don't understand our diets, our needs. And so I do think it makes a difference.
Definitely.
And if you open up to them to say, well, I understand how difficult it is because, we go through that as well.
Definitely. And diabetes as well. We have sessions around diabetes, and you mentioned, actually tailoring it to that specific, group. Like you mentioned, South Asia, you're talking about diabetes and you're talking to South Asian, the information you're going to give about diet, the leaflets, the food, recommendations you're going to give, it's going to be very different. Yeah. You know what? We get a lot of our patients, we get people like, we mentioned people are coming from all over the place, and the first thing when they come in, they're like, I want to see a gynecologist, and then having to explain the process because it's not as we don't have gynecologists in primary care, so explaining the system and saying actually, we can try and help you with what your issue is, but then yes, we've got secondary care, wait times. I mean, should I not get into that? But I think a lot of it is that communication, understanding different systems. How do we work better?
So I think, I have 2 or 3 ideas. The problem is, whatever ideas you might have, however you might want to work, it all boils down to the lack of resources to be able to set something like that up. So the first thing I think is we don't really interact or get to know our primary care colleagues and vice versa. And I think that's one of the biggest barriers I feel. And there should be kind of more regular education, whether it's educational meetings, whether it's social meetings, whatever. There needs to be that interaction there so that, we can understand their challenges. It's one thing kind of, reading policies and knowing how, I think we're all aware of the pressures on primary care and GPs and their time. And I have the greatest respect because, gosh, they need to look after everything, isn't it? A patient could come with anything and expect them to know and solve that problem. We all are our niche, Yes, I can talk about everything obs and gynae because that's all I do. But what about all the other things? So I think, and vice versa, they can understand then our challenges as well, which we face there. So I think that's one thing. If we can somehow have more kind of meeting interaction between primary and secondary care colleagues, that would be helpful. The second thing, I think, just as you mentioned, if we'll just talk gynecology because that's who I am. So women come expecting to see a gynecologist. Why is it that we cannot have, say, once a month, a clinic where a gynecologist can be present for you guys to have, triaged some women who truly will benefit, and I must be the most hated consultant in GP land. I'm telling you why, because I am tasked with triaging all the general.
Are you the person who rejects all our referrals? Guys.
So, don't lynch me. But what I was trying to get at is, there are several referrals which I hopefully don't reject outright anything. I send back with advice on, why would you like to discuss this with her, or could you do this before referring her on? And there are so many where, women, and particularly women from our kind of the diverse background, because they're used to, in their own countries, having straight access to gynecologists. So sometimes they just feel like, if we tell them the same thing which you guys might have told them, they'll take it. But, they feel because that's coming from a specialist. So many a times, all they need is just a conversation and reassurance that, whatever is happening is either normal or they should try this and that will help them. So can we not have like a session, say, every month where a gynecologist comes here and is available to women? Again, the problem is, that whole kind of funding stream, who's going to fund that gynecologist's time to come? And I think, the way I look at it is, there's a big NHS pot. Why can't it be kind of equally distributed? Why do we have kind of these, well, this needs to come out of secondary care, this needs to come out of primary care? Even simple thing like prescribing. We see patients in clinic and then we are not allowed to prescribe from the hospital. We've got to write to the GP to prescribe. I mean, just think of that poor woman kind of, now having to go back, contact her GP, with you guys getting kind of, probably millions of letters from the hospital. I say to them, don't wait for your GP to contact you. When you get a copy of that letter, just assume they would have received it. You make that contact because I'm not wrong, isn't it? I mean, how on earth will you be able to look at all the letters you get every day and then contact the women or men, I'm sure. Yeah. So there's a lot of that, those bureaucratic pathways that have been made, which we have no control over. And I'm sure they're there for a reason. But somehow within that framework, we've got to find better ways of communicating between each other.
Definitely. I think, like you mentioned, at the moment, the process is, yes, we refer you, but actually if we're talking about funding and looking at that patient's process and actually waiting, if they come to us, they present with something, and then we're saying, okay, well, I'm going to refer you, and then it takes a couple of weeks, it goes to you, and then you'll think, actually, that's not appropriate. We could have just stopped all of that and, said, actually, once a month we have a clinic, why don't you pop down? Maybe this is the sort of thing, have a little topic or an area that we focus on, and it's just done there and then. You've got, a lot of it is education, isn't it? A lot of it is just
absolutely. And there are so many kind of procedures which we can just help our GP colleagues to, for instance, I know there are many GPs with a special interest in women's health. If they can be I wouldn't say taught, but kind of, just given that confidence to do certain things, for instance, for prolapse, inserting pessaries is a fairly simple thing to do. The number of women who get referred to us because they went for a smear test and have a little polyp on the cervix, totally simple thing to remove. Our GP colleagues or even that practice nurses, those who are doing smears can easily be trained. So, why can we not come and train a group of practice nurses to do that procedure. That's I can tell you that's at least 10 referrals a month, which won't need going there. So a lot, and I'm sure there are lots of things which can be.
And this is where that just sitting down together, not one of those meetings for the sake of having meetings, but actually having a meeting where you can look at these processes and, from a patient's perspective, and actually bringing, like you mentioned, bringing patients into these discussions as well.
That's the key, actually, because, women will tell us what they want. They don't want to go rock up to the hospital. That's the last thing they want. They would much prefer coming to their local surgery, which is where they feel at home. And they will tell us, this is how we want you to. And then it's up to us to see, well, what is doable? Of course, we have to manage expectations as well. We can't achieve everything, but we can start from small things. Yeah.
Brilliant. Thank you so much.
Pleasure.
Hopefully we'll have many more meetings and discussions in the future.
Thank you.
Thank you.